And whilst we're waiting, I've got a few pictures for you to peruse. Here we go. Right, I think there's a bulk of people kind of filtering into the room now, so we're going to get started. Let me begin by saying hello and welcome. Some of those slides you've just seen possibly hit home if, like me, you're a fellow data professional. If you have any other visuals that sum up working with data, then spam the chat with them now. I'm always happy to collect some of these visuals. Thank you for those people that contributed those last ones to me. I try and use them wherever possible because working in the real world is always a little bit more challenging than kind of textbook examples. Right, so let's begin now. I'm Stephen Simpkin, and you're going to hear from me a bit today in this session in chapter 2. But don't worry, in this time I'm only talking for kind of 10 minutes because in chapter 3, so we want to focus our attention, we've got examples of 3 pieces of work from across our wider partnership that we want to be sharing with you as kind of use cases. We'll hear from Lucy Clayton from the Fire and Rescue Data team. She'll be returning to her soapbox once again to bang on about data. That's not me insulting her, those were her words earlier from the first session, if you're in that. More or less her words. We'll also hear from Alice Lowe, who will be sharing some work she has been involved with in a kind of joint role she has, a kind of senior analyst within the data analytics team at Essex County Council, but also working with the Mid and South Essex kind of health partnership teams. And finally, we'll also hear from Amos Turin, who is a senior analyst here at Essex County Council. He's going to close with an example of some analytical work kind of wrapped up nicely in a modern data output. But first, I'm going to pass over to Greg Middleton. Greg is the Strategic Head of Partnerships and Delivery at the Essex Fire, Police and Crime Commissioner's Office, and he's going to get the ball rolling in this session. So over to you, Greg.
Yeah, thank you very much, Steve, and welcome everyone. It's good to have you all on the call for what I'm sure will be an exciting and engaging session. So Steve just asked me to open up by saying a few words about the importance of data and analytics. So I'm going to get my borrow Lucy's soapbox with pride, and it just made me reflect on how operating, as I'm sure we all do, in an environment of restricted budgets and what feels like an ever increasing demand on pretty tight resources means that we need to make sure that every bit of resource and every bit of capacity that's available to us is utilised in the most impactful and meaningful way possible. And this means using data and evidence and analysis to predict and project how and where we should be targeting what are pretty precious resources. So understanding and harnessing that data, the data that's available to us, may tell us which initiatives are the ones that are most impactful. It might pinpoint hotspots or cohorts of people that are most in need of services or support. Or it might also challenge traditional thinking or maybe some of the noisy minority that sometimes dictate how we invest or deploy our resources. I think for me, I've seen the difference that data and analytics can have when making some strategic decisions. I don't think any one of us like being in a position to have to make difficult choices about where and how to invest resources. That can feel quite scary. I'm sure we'd all love to be able to do more, but being able to demonstrate why we're making the choices that we are and having the evidence to then back up those decisions can be incredibly powerful. And that's both for internal decision making, but also when we're being viewed through an external lens and responding to scrutiny about the decisions that we're making. So today we're going to hear about how data has influenced the targeting of fire and rescue resources from Lucy to protect the vulnerable people that might be at increased risk of fire. Working with both Essex Police and the Fire and Rescue Services I have done, I've seen a number of other examples of this, including targeting specific schools that we feel will benefit most from an input from our joint education team, targeting home visits for those individuals most in need of advice and support about issues like fire prevention, hoarding, but also falls and community safety advice to try and prevent things happening before they do. And we see the same data-led approach being taken by Essex Police in protecting communities by deploying high visibility patrols at the right times and in the right locations. By taking this approach, we can make sure that we deliver the best value, as well as having a tangible impact on people's safety. We'll hear other examples about that today, as Steve said, and I'm sure that you'll all have some experience yourself of taking these sorts of approaches within your own organisations. I love the description of this event as analytics in the real world, and I think as some of those pictures demonstrated, you know, there's a recognition that we might not always have the perfect data set available to us, or we might not have every unit of information that we want. But I think the point is, don't be held back and constrained by that. I think making the best use of what we do have available to us, we can genuinely improve lives for our residents and for the communities of Essex. So thank you very much for attending today. I hope you enjoy the session. That's it from me. I'll hand back to Steve.
Lovely, thank you very much. I'll quickly add actually here, while I was there, that about 16 years ago, Greg and I kind of joined the same research and analytics team in the same role within about a month of each other. They're kind of essentially were junior analysts at the time, and we've kind of gone in separate kind of career directions from there. So where I've kind of really sank deep into the kind of data weeds, and my role is about using data to provide evidence to decision makers like Greg. Greg took a kind of slightly different path, but his role still involves seeking out that evidence to support the decisions that he's involved with. And it's really great that having those kind of data routes actually does enable different career trajectories as well. But data analytics, as you've just kind of heard, remains critical and crucial to kind of both of our roles. So there we go. I just want to share that. It's a bit of a modern retelling of sliding doors, but with data. Right. So before we hear some of those examples of applied analytics in the real world, I thought I'd best cover the different types of analytical solutions that a modern analytics team might use. And there's probably a few different profiles of people that are present here today. Absolutely fantastic to see. But I think a large chunk will fall into one of those kind of two categories I've already discussed, really. So either you work in or around a data analytics or business intelligence or research team, and you regularly have people coming to you with a business problem, and it's kind of your role to figure out where data and analytics might help. Or you might be in one of those more strategic roles or operational roles, and you're looking to see how data and analytics and research can give you the intelligence and evidence to effectively tackle some of your problems and challenges. And the good news is that this session is for both of you, really. So turning a problem into a data project is not always straightforward, as we've kind of seen already, and it kind of needs both of you to come together, both of those roles. Right, very quickly on your screen, you'll see the classic data science Venn diagram. So data science ways of working and outputs are kind of fast becoming a bit more normalized now. So it's not hugely different to how analytics and research has always been conducted through the 90s and noughties, and I remember doing those. It's always required components of subject matter expertise, domain expertise, mathematical and scientific methods and statistical skills, research skills, and so on. Though I just wanted to include this here to show that additional component on the right hand side here, and it's kind of effective ways of managing and working with big data, really. So increasingly the work is starting to require a little bit of those programming skills in modern data practices. In absolutely the simplest terms, in terms of the work an analytics team might do, I tend to think of it as kind of get data, do something with it, and then put the important information in the hands of the people that need to see it. But everything always starts with a problem, and it can be fairly high level and vague at first, but you'll probably ultimately end up reframing it as you start to pull together a bit of a work plan. So here at the top of your screen, you'll see an example I've used about social isolation. The problem is social isolation significantly increases risk of premature death from multiple causes, but it could be anything really. And there are many ways you might start trying to unpick this problem based on a couple of things. So one, what you need to know, and two, what you'd like to do. So we're starting here on the screen with what you need to know, and I'm using the Gartner Analytics Maturity Chart. I think Nikki had that in an inaugural session of the day. But broadly speaking, you might want something of this design. So either descriptive information. So who are these people? Who are these isolated people? Where are they? How many are there? You might want some diagnostic intelligence. So what is causing the isolation? What is the impact of someone being socially isolated? What type of people are isolated? You might want a bit of predictive intelligence. Who's most vulnerable? Where might we target? What resource do we need in order to do so? Or potentially, on this right, prescriptive analytics. So what is working in reducing isolation, and when or where might we intervene, and how? So all of these things have merits, but it might use different approaches depending on what is most important. And of course, there's a what would you like to do? Might be doing something differently. This will also help determine the various analytical options in tackling the problem. So a lot of work from analytics and research teams are to provide intelligence to support people to do their job as effectively as possible. And that's incredibly important. So we want people to have access to the best intelligence in a timely way to inform their decisions, their strategies, their operations, their business cases, all of this. So intelligence that we create to feed into strategic documents, business cases, needs assessments, absolutely fantastic. That's the kind of bread and butter of an analytics team, really, because we don't want the opposite. We don't want these things not informed by evidence. I guess the reason I'm highlighting that is not every single piece of work is going to directly result in kind of 10,000 fewer hospital admissions or 10 million pounds worth of kind of cashable savings or 50% increase in satisfaction. What we want to do might simply be along the lines of we need a better understanding enabled to continually support service delivery. And that comes from a really good descriptive and diagnostic analysis. Having that good understanding of what's happened before does then open the door to look at these last two parts of the maturity chart, so the predictive and prescriptive, and I'll work through a quick example of that in a minute. But first, here's a bit of a very high level kind of generic list of analytical approaches that you might start considering depending on what you need to know and what you'd like to do. And there's an overlap with some of these things. There are also many, many more statistical approaches or analytical methods. I'm just kind of putting it up here to give a bit of an indication of the type of work our own team might be involved in. Now, typically, I would almost say that the split of the type of work is almost 60-30-10 from left to right. So 60% of our work probably in this descriptive diagnostic column. A lot of building of evidence. Need to create the evidence base through our descriptive and diagnostic analysis. Then when it's feasible and practical and possible, we might potentially start to look at things like predictive or prescriptive work as well. And we have examples of all of these types of work. We can possibly go through them all today. We've got a few examples across this kind of spectrum, but we do share our work through things like our Insights blog, which I'll then share a link to at the end. We're hoping to have a kind of shared area where we might share more case studies like the three we'll hear about today. Right, however, what you end up doing will be determined by a lot of other things, not just the problem and desired action. So things like availability of data, historic research and literature, ethics, governance, etc., all could impact upon the eventual work you end up doing as an analyst. So here's a quick example of the same problem we had earlier. We've got our social isolation, increasing risk of premature death. So what we could do, target our interventions to the people that need it most. It's kind of prescriptive analysis. So all we really need is a list of everyone in the county that's isolated, and then we'll go and give them this perfect intervention. Sorted. No more isolation, problem solved, absolutely easy. But we know that that's not the case. And if you were here at the start, you would have seen this slide. So we've got Olaf here on the left and oh my dear God on the right. And if it was as simple as that previous slide, then in all honesty, someone would have done it already. Very rare you have that real simple obvious approach you can take, which is why I think a really good experienced analytical professional are so high in demand right now, because a lot of those real easy obvious solutions have been exhausted, and a lot of the time it's okay, what are the marginal gains we can have? Or I think Lucy used the words earlier, minimal viable product, which is fantastic. I think there's a lot of value to be had in, okay, we can't do our dream thing, what's the thing we can do, and what will the impact of that be? So let's revisit that problem and talk through it. And this is mostly kind of fictitious, but based on real life events, so a bit like Towie. And first up, the first problem with here is it's very, very rare that there is a one size fits all intervention that's ready and waiting in the wings. And we just need to just ensure it gets in the hands of the right people. So we're unlikely to ever start with kind of prescriptive analysis without a hell of a lot of work before that. So this very quickly changes from what it initially was to, okay, so just tell us who we should be approaching, and then we can think about how best we might intervene. Unfortunately, though, social isolation isn't this nice census question which is captured between kind of age and number and card and household. We don't actually know this, not hard coded. It doesn't exist as a captured measure for the entire population. And then that is actually quite symptomatic of a lot of things we are interested in. It just doesn't exist as a nice variable. Same with things like A&E admission risk. There isn't a box being checked somewhere that tells us that so-and-so is an A&E admission risk, or we don't have a box which is this person doesn't recycle at all, or this household is a fire risk. So not as straightforward as having this off-the-shelf variable in order to determine what we want to do. So therefore, we might start thinking about a kind of predictive model, or supervised machine learning, to use a term which is kind of generally used now. This is where we would take the historic information and we'd look to determine what were the events and characteristics that resulted in that outcome. Then we apply to future cohorts. So what caused those dwelling fires, and therefore which households have heightened risk, or what led to these historic A&E admissions, and therefore who is vulnerable to an admission in the next 12 months. So while that can work in some circumstances, and we'll hear some examples later, social isolation as a measurable thing only kind of really exists conceptually. There's no real hard data on this other than in kind of ad hoc or disparate pieces of research that people have done. So we can't actually do a supervised machine learning model either, which then naturally, hypothetically, takes me to unsupervised machine learning, or kind of cluster analysis for those in the kind of analytics profession, or profiling, but that's the word we don't like to use. This is when you don't have a hard metric to point things towards, and you're looking for patterns within the data that groups people together. So perhaps we could take data for things that we know are risk and resilience factors for social isolation, and we create different groups with different needs and vulnerabilities and potential interventions. But I guess my next question then would be, well, do we know what these risk and resilience factors are for social isolation? And do we have data on those risk and resilience factors? And often we don't, as problems like this are quite often more complicated than meets the eye and a bit more multifaceted. It's not quite as simple as, are they elderly, living alone, retired in a rural area, or what have you? So what we ended up with was a bit of a diagnostic. And that diagnostic really helps build the evidence base when you combine it with your national literature, your secondary analysis, some simple segmentation, though, who are the risk profiles, and what type of output then wouldn't really be suitable for targeted households. You've built a good evidence base, but not enough to be able to target individual households as you might initially have started, but could indicate key groups, key cohorts, or key geography. So again, that's kind of changed slightly. And all of this was absolutely fantastic intelligence. And actually the final diagnostic and final kind of work was featured on BBC News. And whilst it might be disappointing that we didn't have this super model that pinpoints exactly where to send interventions to, we did arrive at something which was proportionate, insightful, evidence-based, and achievable, and something that could enable some confident action. And you can quickly start to get this refined picture of what might be possible with each problem and what probably isn't feasible. And identifying what isn't possible or likely is also really, really important. So you can have all the data, all the skills, and all the willingness to act in the world, but quite often an experienced professional might feel that the likely data outputs might not quite get you to a position where you have enough confidence to take the action you might want. But definitely this is the type of thing that you need to come together with your kind of subject matter expertise, the people that want to deliver some actions with your analysts from the very beginning, to bottom out at the very start. And if you can do this quickly, you can then pivot to something which is feasible and still impactful, that minimal viable product, what can be done and what will the impact of that be? Because there is always something, absolutely. It might not be the kind of dream scenario you began with, but there'll be something you can do there. Right, that's going to be it for me, and we're going to see some examples now. What I'm going to ask people to do as we go through these, if you have any comments or questions, please do use the chat here. We'll try and mop them up if we have time at the end. What I'll say as well, we've got a few examples of case studies we're going to share here, but we're continually keen to share the work that we're doing. The examples we'll see range from that kind of diagnostic to predictive space, building up that understanding of historic patterns to make recommendations for future activity. And also we're looking at an example that shows a modern data output. So what they all have in common, though, is they all started with a problem, followed by that kind of careful consideration for how best to tackle. And with that in mind, I'm going to pass you over to Lucy now, who's going to work through our first example. Over to you, Lucy.
Hi, and welcome everyone to this afternoon's session. So I'm here to talk to you about it's not going to click me through. Stephen,
Okay.
have you given me permission?
That's all right. You should do, yeah, but I'll get you started and we'll try and figure that out.
So what was the problem for Essex County Fire and Rescue Service? So between 2009 and 2017, 80% of the casualties recorded in Essex County Fire and Rescue Service were a result of an accidental dwelling fire. So that's what would traditionally be a fire in the home. And in 2023, there were 742 home fires within Essex, accidental ones. And within that year, tragically, 12 people lost their lives. Accidental dwelling fires are preventable. They're usually caused by distractions, falling asleep, or excessive or dangerous storage of items. Yet in 2021, from accidental, the fatalities from accidental dwelling fires were higher than they'd been for the 2 previous years. As well as preventing harm, the loss of life and the personal devastation experienced by many, reducing accidental dwelling fires can also have an impact on our economy. The cost of each accidental dwelling fire is estimated to be about £43,000, and each fatal fire is estimated to be around £1 million impact to the economy. So for a fire service, it's not just essential for us to be responding to the incidents, but we have an obligation to prevent those incidents from happening. And if those incidents do happen, I've been able to ensure that people are informed and educated enough to get themselves out of the property in those scenarios. We have, like all public services, we have limited resources and limited budget to deliver this work. So we need to understand where those people in our communities are. As a fire service, we've got really rich information about the property, which is what is on the screen. We have really rich information about the property, but we have very limited information about those that reside within the property. Member of my team always said it'd be great if people took out an insurance policy with us, because we'd be able to take a lot of information about them and been able to target our resources, but unfortunately we don't. This is a conversation that we had quite frequently with our partners, and I think I spoke about this in probably many different EXA presentations in the past, so apologies if you have heard this before. We knew that the people that we were interested in as well within the fires were probably also of interest in other public services. So if we go to the next slide, Stephen. So what we did is we worked with EXA, and I can see Tom is actually on the call and he was involved in part of this, the initial iteration of this as well, is that we spoke about the problem with them. So this is the issue that we've got. For those that were on the call this morning, you may have heard me talk about the beg, borrow and steal principle in terms of staffing. We were that tiny team at the time. I had a performance analyst and I had a system and data officer, and we didn't have the capability and probably not the full skill set that we needed to truly understand those people in the properties. Tom was very proactive in hoping that we could do something in a partnership between us and Essex County Council, in the hope that actually if we learn at joining our data together and establishing links between the data, we may be able to build a model that will allow us to identify where those people may be within the communities. There was lots of conversations about IG and ethical processing in there, because, you know, I'm sure everyone on the call's tried to do data sharing in the past. It's not always as easy. And we knew that the data that we wanted to access was going to be sensitive data in order to do that joining, at which point Tom and the team were happy to do the initial stage of the modelling for us. If you want to move over to the next slide, Stephen. There we go. So this is the actual data solution that came out of the solution. So we've got 4 different clusters that we were able to identify within Essex in terms of risks for accidental dwelling fires. So we found out quite a lot of information as well by joining those clusters together. So our cluster 1, which was the most vulnerable, we can see that they are sort of like your urban hubs. You've got a dot over Colchester, you've got a dot in Basildon and over Southend as well. And they had significant challenges. And actually 10% of our accidental dwelling fires occurred in just 7 of those wards. What was quite interesting also, we saw within the wards there that the proportional smoke alarm ownership was actually high. It was well over 80% in terms of smoke alarm ownership. And one of our strategic commitments was to ensure that everyone in our communities had smoke alarm ownerships. So it was really interesting to see actually that our highest risk cluster also had the highest ownership of smoke alarms, whereas if we went to our cluster 4, which was the small town and rural settings, while they had fewer fires and less severe fires, they also had lower levels of smoke alarm ownership, at sitting around 61% on those. We also identified by joining those data sets together that 36% of those victims of the incidents were actually known to adult social care. We didn't know who. The data was aggregated and anonymised for us, so we wouldn't be able to drill down into those premises at Essex Fire, but we knew that there was a correlation and there was a link there that was really interesting, and actually for us was an enabler to opening up conversations with partners to say, actually, we should be sharing more information because we know that there are links there. Probably unsurprisingly, that 58% of fires are actually started in the kitchen, and 18% of those, the first item ignited was food. So if you follow us on social media, you'll see lots of campaigns that we undertake about cooking, about distraction around cooking, about food being cooked. 41%, the first ignition source was ovens, cookers. No real surprise if we can see that they're happening to food and in kitchens. But what was actually also really interesting, that was in households of lone occupants, we were seeing 12% of those incidents were started from the microwave, which would suggest the ding dinners where people are maybe reheating food from the night before or having ready meals. So we got lots of useful information about that, and what that enabled us to do as a fire service is prioritise the people within those areas. So we are proactively targeting those people in the highest cluster areas for access to our home fire safety visits, which are free offerings that we do out to our communities. We will go to people's houses, and this can be anyone in the community, for free. We will install smoke alarms, and we will also give fire prevention advice to those people within the house. But it allowed us to have more targeted conversations with those people as well. And it became really valuable. In terms of how we practically use this within the service as well, we had a room set up in our main building as we launched this out called the risk room. And the wall was covered within the map, and we had the information about the different clusters on the wall. And once a month, the prevention team were going through and reviewing who had come through the process, understanding where the blockers are, getting more information that they fed back into there, and feeding that back into the model. So they were understanding not only the data that was coming out of it, but they were evaluating as they went to make sure that those interventions were having the impact that we intended to do. If we can just go to the final slide for my section. So the what next? So I just thought I'd mention this briefly, as we have kicked off a new project within our team at the moment. And this is the icon for Prometheus, if you didn't know. Prometheus is the Greek god that gave insight to the humans in order to give them insight. We've adopted that name in terms of developing our own risk models. As Stephen mentioned, we've coined the phrase in the service, the minimum viable product, when we're rolling out our products. So we are building, now we have the capabilities in the team, we are building our own data science model, a risk model. It's a severity and frequency model, and our first minimum viable product is using the data that we have easily accessible to us within the fire service. So we're using our incident data, we're using indices of multiple deprivation, we're using the profiling tools such as Acorn, we're using some NHS data that the fire service has accessible to us, EPC data, and lots of information like that. So we can identify those persons within our communities that have had fires and understand the attributes about those properties and those locations to help us identify where other people may be within the county. We are sort of like within a few weeks away of launching that as a first risk model out to our teams, and we're asking them to use that risk model, understand it, interact with it, and provide us with the feedback. Our next iteration of the model is that we will be looking towards our partners to understand if there's any data as part of that model that would help us add to that, understand our communities a bit better, and further target our resources. And we're about to set our 5-year strategy on the back of this data, and we'll be constantly reviewing it as we go. But it's been a real valuable, this whole process that we've been through. We talk about a phrase quite often in the fire service. We've got our known knowns, which is we know where the properties are happening and how those incidents are happening, and what is the ignition source and the reasons behind those incidents. And we've got our known unknowns, which is about the people that were within those. And that is our biggest challenge that we need to achieve, is understanding those unknowns and how we can target our communities and make them a bit safer. But that's my bit, Stephen.
Lovely, thank you very much. I think over the last couple of decades, there's been a real nice, rich history of kind of fire and rescue services, looking at the kind of upper side of that data maturity kind of chart I showed earlier, and looking at that prevention type work, because I guess it's an operational model. Sitting around and waiting for fires to happen isn't the best way to do it. And I mean, I guess there's lots of really great national research of the London Fire and Rescue Service and how they were one of the first to look at that kind of prevention work. And yeah, personally, I think it's been good to see your team grow and really kind of see the value in data, because I think when I first started, we talked about your team, that was just you and one other person, if I remember rightly, like 15 years ago. So good. At least there's more than that now.
I'm growing them slowly.
Lovely. I'm going to move on to our kind of second example, and hopefully, Alice, if you see you're able to take over. The perils of working in partnership is not the technology doesn't always want you to, but Alice, hopefully you should be able to. Have you got access now?
I should do. It's not allowing me to move on either. It's saying I've got control, but I'm going to have to ask you to move on my slides as well.
Yeah, that's fine. Just next slide me, that's fine. I'll try and do the best I can. Right, let's get started.
So thanks so much. I'm just going to take a few minutes to talk about a pilot project which ran in 2022 called Connected Neighbourhoods. So this project worked as a collaboration of efforts between Mid and South Essex ICB, Essex County Council and consultancy firm Newton Europe. The project allowed the sharing of NHS data to ECC via an honorary contract and was the first project to run on this contract. So previous studies have highlighted a need to move from a more reactive to a more preventative care model and aim to treat people before their needs escalate. So with no real mechanism other than direct GP or general clinical input to identify who may benefit from advanced preventative care in the over 65s cohort, we needed to create a way to support health providers to identify those who may be at risk and escalating need and help them to prioritise and direct people to the correct services. So by advanced or preventative care here, I mean things like advanced care planning and falls risk assessments and reviews of people's medications. The next slide, please. So given that we need a mechanism to identify those most likely to benefit from advanced care, the project aimed to identify who were most at risk in escalation of need and therefore most likely to have a hospital admission in the near future. So this method is called individualised patient risk stratification, and the overall aim of this is to find patients who are the highest risk and pinpoint which types of intervention may benefit them. It's important to note that this tool is not aimed to override GP advice and was only aimed to complement and aid teams. And this isn't about replacing human decision, it's about helping to inform, making sense of the masses of very complex data to help with these decisions. So to create this machine learning model, we first needed to create a data frame, which allowed us to tell the model both information about the patients and what we wanted the model to predict. This meant that we needed historical observations of an event. For our models, this meant that we created a flag, i.e. yes or no, which highlighted if a person had been admitted to hospital or not in the 3 or 6 months after a specified date. And this could easily be adapted to predict the occurrence of any event which has reliable data. And I understand similar models have been used at ECC to predict school readiness and escalation of social care needs as examples. So moving on, we then linked a range of information which is likely to be linked or impact this event, i.e. going to hospital, from a variety of sources. So for example, if they had previous admissions to hospital or certain health conditions. We built this picture of someone's health profile incrementally, meaning we were able to test how the model responded to being changed and tweaked over time. And this is called feature engineering, and simply put, involved transforming messy, large and complex, unlinked raw health data into a nice, neat, usable table, otherwise known as a feature matrix, which we could feed into our model. Next slide, please. So to create the model and check its accuracy, we then split the data into training data and testing data. We ran our training data through the model to teach our model what the data looks like given someone will or will not be admitted to hospital. We were then able to assess how well our model performed by using our testing data. This meant that we removed the answer from our testing data and made the model predict the answer without knowing it. And this meant we were able to check the model if the model had correctly predicted the results or not. These predictions could be split into correct predictions and incorrect predictions. The correct predictions would be where, for example, someone was predicted not to be admitted to hospital by the model, and we were able to confirm that they did indeed not go to hospital. And this was called true negatives. Conversely, if someone was predicted to go to hospital and they were found in the data to also go to hospital, these were called true positives. Conversely, if the model predicted someone to not go to hospital, but we actually found out that they did, this was a false negative. And if the model predicted someone did go to hospital, we actually realized they didn't, this is a false negative. We then ran different feature matrices using different information about our patients through different model types, tweaking things over time to get the most accurate model in order to maximise both the number of true positives and true negatives. The next slide, please. So from our model, we're able to then rank people who are most at risk of escalating need at each GP practice. It's important to note that no model is 100% accurate. So we know that the model may well have got this wrong occasionally, which is why these types of models do not replace clinical advice. However, we were able to predict with over 70% accuracy in this first pilot phase who is likely to benefit from advanced care, with even higher accuracy in the cohorts most at risk of hospital admission. Next slide, please. So overall, this was just a proof of concept pilot phase and has not been moved into the production phase yet, but it works to give an idea of what could be possible to help our medical professionals when dealing with huge volumes of data. There are many benefits for using machine learning models in healthcare, and these include things like helping with early detection and prevention, and by analysing patient data and identifying risk factors, this can lead to proactive healthcare interventions, reducing the overall burden on the healthcare system. Secondly, these models can help with improved healthcare decision-making, where machine learning can enhance decision-making processes by analysing huge amounts of healthcare data and assist in identifying patterns and optimising resource allocation. Using machine learning and advanced analytic models can also help with creating personalised treatment plans, and this can lead to more effective and targeted interventions, improving patient outcomes and satisfaction. And finally, machine learning can help optimise healthcare resources by predicting demand, identifying bottlenecks and streamlining processes. This can lead to cost savings and improved efficiency. There are, however, some challenges and considerations we need to remember when using these types of models. The use of machine learning in healthcare raises concerns about patient data privacy and security. At Essex County Council, we're very aware of information governance legislation and ensure we follow guidelines fully. And all analysis for this was completed on my own NHS laptop to ensure no transfer of data outside of the NHS, along with all data being anonymised, meaning I wasn't able to identify who the data was that belonged to. Furthermore, integration of machine learning systems with existing healthcare infrastructure may require overcoming challenges. So, for example, simply by adding a new tool for GPs to access to understand patients' risk for individual diseases or episodes, this would not work in an already stretched system. We need to find ways to incorporate results and predictions into everyday ways of working. Next, there are ethical considerations to note. Specifically, algorithms may inherit biases already present in historical healthcare data. For example, where certain cohorts may access certain types of healthcare differently to others. And we actively work to address these biases to ensure equitable healthcare outcomes. And finally, implementing machine learning in healthcare requires people with the necessary skills. Systems may need to invest in training programs to upskill existing staff and hire individuals with expertise in machine learning and data science. So thank you.
Lovely, thank you very much. I think for a while that kind of integration of health and social care intelligence and operations has been a bit of the holy grail, really, in that it's potential to be one of the biggest game changers. But for something so important, I think there is even more kind of challenges, even more kind of scrutiny will be placed on it, because at the end of the day, it's talking about people's health and care. So good to see those kind of bullet pointed challenges there, ones not to be taken lightly. But excellent, thank you for that, Alice. We're going to swiftly move on to our third case study, and I'm going to give it one last try to see if we can get the share screen working. So Amos, I don't know if you're able to take over. If not, we're going to next slide our way to the final.
I'm attempting now, and I think I'm going to have to request next slides again, but by now you're used to it. Yes, so thank you very much. My name is Amos Turin. I'm a senior analyst in the data and analytics team at Essex County Council, and I'd like to talk about some work we've recently done on digital exclusion, which we did to support Essex County Council's digital connectivity team. Next slide. So let's begin with a little bit of context behind this project. Nowadays, an increasing number of services and day-to-day activities are moving online, as you all know. As a result, residents with poor or no internet access might be adversely impacted both economically and socially. Now, what's more, according to peer-reviewed research, they find that digital exclusion is more likely to occur among vulnerable groups in the population. Now, this shift online is therefore expected to compound challenges that are faced by these vulnerable groups. Think about, for example, people who may no longer be able to visit their high street bank branch, because it's closed and has moved to an online-only service. Or another example would be how someone who's unemployed might look for and apply for jobs. How many opportunities would they miss out on if they couldn't search online? Or another example would be a person trying to book a GP appointment or get in touch with their local council. How difficult is that going to become over time without internet access? Now, to add an additional layer of complexity to this, Openreach have now begun switching off the old copper landline networks across the country, and they're gradually replacing these with new digital and fiber infrastructure. This process is already underway, and it's expected to be completed by 2027 across the whole country. So what happens when already vulnerable groups no longer have landlines to rely on? Some residents have medical devices in their home that connect directly to the NHS, and they make use of these landlines. What happens to them? So for all these above reasons and more, which I haven't mentioned, Essex County Council's digital connectivity team approached us last summer to find a way, using data and analytics, to identify the population of Essex that is either already or is at risk of becoming digitally excluded. Now, on top of that request, we also wanted to find a way to generate insight that would help the digital team design tailored interventions to support these residents based on their unique needs. Next slide, please, Stephen. So we kicked off the project with the following research question. Who and where are our residents who are most susceptible to be digitally excluded? This question can then be broken down further into two sections, the who and the where. So starting with the who, we searched through the academic literature to understand what the key barriers to digital connectivity are. And what we found is that there are three primary barriers. The first, accessibility. So this has to do with the presence of internet or mobile infrastructure and service provision, without which you cannot access the online environment. The second barrier was affordability, which means the financial means to pay for such services, or alternatively, to be able to afford the devices that you need in order to connect, such as laptops, smartphones, or tablets. And the third barrier is ability. So ability can either be the skill to confidently utilize digital platforms, otherwise known as digital literacy, or alternatively, ability could also mean whether a user has disabilities that could inhibit the use of digital platforms or services. Next slide. So next we address the where part of the question. Now that we've identified these barriers to digital inclusion, our next step was to find data sets that would allow us to quantify the extent to which each of these barriers existed throughout the county. Data that we ended up procuring included, but was not limited to, the ONS Census 2021 demographic and educational attainment data, which could give us indications of the proportion of older age population across the county or the population qualifications and skill levels. We also obtained universal credit claimant data from the Department for Work and Pensions, which could give us an idea of households or individuals that might experience the affordability barrier. Data on existing and planned superfast internet and fiber infrastructure, as well as maximum broadband speeds from Ofcom, along with also mobile data provision levels as they're reported by the mobile network providers themselves. All these could give us an idea of where households might be more at risk of experiencing the accessibility barrier. Now, each one of these example data sets, and a few others that I haven't covered due to time limitations, gave us some way to either directly or indirectly measure the prevalence of one of the identified barriers that I mentioned above. But each of these data sets also contained geospatial data at various levels of granularity. So some of the data that we had was broken down by LSOA, and LSOA is lower super output area, which is typically an area that has between 400 to 1,200 households, or if you look at resident population, it's between 1,000 and 3,000 people for every unit, LSOA. Some of the data was broken down by postcode. Some was broken down at the UPRN level. So UPRN is unique property reference number. So that's individual unique properties and residences. And some of the data was even at longitude latitude level. Now, with this geospatial data, we could now take each of our measures and layer them on top of each other on top of an interactive map. And with this map, we could then easily identify areas where multiple risk factors coincided, and therefore these areas would be more likely to have groups of residents at risk of digital exclusion. Not only that, but now by having the insight into which risk factors were more prevalent in a certain geographical unit, say in a specific LSOA, we could now, as a result, tailor a specific intervention to support these residents based on their particular circumstances. Next slide. So at this point, maybe it'll be easier if I made things a bit more tangible by actually showing you, demonstrating what the actual tool that we built looks like. So Steve, at this point, I'll just kind of share my screen. Let me see if I can get to it quickly. Right. Hopefully this is on your screen right now. I can't see anything, but Stephen, quick thumbs up if you can see this.
Yes, I can see your screen. Yeah, fantastic.
Okay, perfect. So what you're looking at here is a map of Essex, including Southend and Thurrock, that is broken down by LSOAs. So each of these kind of boundary areas of various sizes represents a single LSOA. And this map actually has behind the scenes, under the hood, all of these data sets and more that I mentioned, and we can filter by them. So if I open up a filters tab here, we can now check various criteria and see what LSOAs those criteria exist in. So let's do an example demonstration. So you see, we can see on the top right screen, there's a total counter of 1,100, slightly over 1,100 LSOAs, and that number and the map will change as I make selections. So for example, NGA classification tells us where is data regarding where either gigabit or superfast internet infrastructure are either already existing or planned to be laid out. So for example, we can select LSOAs where no service exists or is planned to exist for gigabyte or superfast internet. So we see the LSOA counter just dropped to 795. Then we can further make selections. So we can look at affordability criteria. We can say, let's overlay that with LSOAs that have a very high proportion of households that have a low discretionary income, which is after all monthly expenses fixed and also groceries, they have less than 125 pounds discretionary income. So you can see there's the LSOA count has dropped even further. We can then check of these LSOAs, which of them also have a very high proportion of universal credit claimants. And let's say we're a project team in the digital connectivity team, and we're focusing on interventions for a specific district right now. Let's just select Southend-on-Sea, for example. And we see now we have 17 particular LSOAs counts that meet all those criteria that we just filtered, and the map is focused on that area. And if we hover over any LSOA, we get additional information. So we can see this LSOA is Southend-on-Sea 013B, and we can see some additional information. So we can see the percentage of households in financial hardship, so that have a low discretionary income, proportion of the population over age 75 that live in the LSOA, people with disabilities, people on universal credit, and so on and so forth. So not only do we know, we can then use this information to think about what kind of interventions would be most suitable for the residents of this LSOA. Now, what you don't see here, but that is an option that exists also for the digital connectivity team themselves, is the digital connectivity team at this point can export a table of the actual physical addresses in each of these LSOAs. Again, we do not know, because of data privacy, we do not know who the residents of who the people are in each of these addresses, but we can get access to the addresses, and then they can, for example, design an intervention and make contact with these residents by sending out a letter that says you may be experiencing these conditions, and if so, we are developing a program to try and assist. So that is just a quick example of this tool, and it is already in use, and we've received really good feedback so far from the digital connectivity team that have been utilizing this tool. And I'll stop sharing now and hand back to you, Stephen.
Lovely, thank you. Whilst we have kind of 7-ish minutes left, I'll invite you to ask any questions in the chat that you might want to direct to our guest today. What I'll also kind of quickly add is 3 examples of different works there. It's fantastic to see. I think that last one in particular highlights the more kind of modern data outputs in that progression in I guess the advances in technology and volumes of data, and this emergence of data science as a kind of practice has enabled us to produce more kind of dynamic outputs and put real-time information into the hands of people that most need to see it when they need to see it. So I think we'll start seeing more and more outputs like that, veering away from those kind of, I guess, the dark days of the 90s and noughties, where you'd have these kind of detailed Word documents that people would have to read through hundreds of pages of things. Now it's all about ensuring the right people get the right information when they need it most. I'm gonna quickly drop a couple of links into the chat where you'll be able to find out more about pieces of work like those you've heard about today. So the top one is our Insight blog, and on there we like to try and work in the open, and we share what we're working on, how we're doing it, and just ways of working in the public sector. And the second one is our Essex Open Data Portal, where we'll quite often publish data products like those we've just seen as well. Doesn't look like we've got any questions coming into the chat, but we have various other use cases like the ones we've talked through today, and in the future we're hoping to have a shared area where we can share these kind of case studies on a more regular basis. So it'll be fantastic to hear from you as to what you'd most like to see some kind of case studies off, and we can ensure that we're sharing the best things possible with the greatest amount of interest. So we've got one question coming in now. Do we publish Power BI products on external facing websites? I guess probably a bit of a sometimes answer here. There's lots of things to consider when it comes to what we might want to publish. I think we've got actually an open data session where we might cover that in a bit more detail. I'm going to wrap up now and thank the speakers today for not only coming along and talking about their work, but for the fantastic effort they put in ensuring they're flying the flag for data and being advocates for data analytics in the public sector. Really seeing some fantastic work coming out, and we're always keen to share as much of that as possible. So thanks again to everyone for coming, and hope to see you at some of the future sessions today and over the next couple of days. Thanks again, everyone. Thank you.